Welcome to another lecture, and today we will be discussing something about the approach to an infant who comes to you with suspected inborn error of metabolism. So, how to manage a patient who comes to you, an infant, okay, who comes to you with a suspected IEM. So, the patient is suffering from IEM, and usually the IEMs, the most common IEMs are autosomal recessive. Some are X-linked recessive, like ornithine transcarbamylase deficiency. So, whenever you have a patient who is coming to you with suspected IEM, we can have three IEM variant classifications that you need to remember. So one is the group one, second is group two, and third is group three. Now you have to understand that the group one defects are of the small molecule defects. Small molecule defects. So here you have abnormality of small molecules. Now here in small molecules, what are there? So there are abnormalities or blockage in pathways of either amino acids or glucose or fatty acid. All these pathways are blocked. So see, what is happening is whenever the fetus is inside the mother, all the metabolites that have been accumulated, for example, the patient is suffering from phenylketonuria or suffering from any organic acidemia, all the metabolites that were produced, which could cause the toxicity, are essentially removed by the placenta. So, when the child is born, the child is absolutely asymptomatic because the placenta or the umbilical circulation is doing what the body cannot do. But once the baby is born and after some days has passed, and there is probably third, fourth day of life, and everything is accumulating, and they do not have any more placenta to remove all the metabolites, this is when the patient becomes symptomatic. At birth, the child is absolutely normal, the delivery is uneventful, and usually the triggers include something like catabolism, or in some cases, huge meals is itself a trigger. Now, group two are the defects of energy failure. Now, here what is happening is that either mitochondrial abnormalities are there or fatty acid oxidation defects are there. Here, what is happening is that the patient is unable to generate enough energy for the daily functioning. So, there is definitely multi-system involvement with hypoglycemia. And the patient usually has a good response to diet. Like whenever you are feeding the child improves. Usually, in the first case, the child worsens, second case, the child might improve. So there is some amount of treatment that can be done in this phase by giving timely meals. Now, third is the macromolecule defects. Macromolecule defects are something like lysosomal storage disease or mucopolysaccharidosis, where the huge molecules that are produced by the body, they cannot be eliminated even by placenta. So these patients are usually very much symptomatic at birth, and they have syndromic phases, they have some abnormalities that is evident at birth. But these patients, compared to the first and second patients, have a more chronic, more subacute, and a very long history. Like the first group and the second group usually comes with acute decompensation, while the group three usually comes with a more chronic phase, with a more chronic abnormality, and usually it does not come to you with acute decompensation. Now, in group one, usually the most common presentation is encephalopathy. Most common is encephalopathy, where the child comes to you with refusal to feed, vomiting, altered breathing pattern, abnormal neurologic sign, hypotonia, rapid deterioration, all that you have. And usually they are something like organic acidemia or urea cycle defect or amino acidopathies. In group two, usually what you have is that there is also some findings that might suggest in the antenatal period, like there is periventricular involvement in the patient, periventricular cyst, ventricular megaly, all that might be seen even in the antenatal USG. And the third is, as I told you, mucopolysaccharidosis. So they usually require no urgent treatment as of the time of presentation, usually. Okay, so the three common system that we are worried about are the neurological clinical features, liver clinical features, and cardiac clinical features, because these are the ones that are acutely detrimental. Even the renal system might be included in the list. So usually CRS is affected by conditions which have hyperammonemia, or there is metabolic acidosis. There might be presence of hypoglycemia. So all this is very much detrimental to CNS. And as I told you that many of them present with acute onset encephalopathy. They might have seizures, they might be hypotonic, they might be twitching, they might have abnormal posturing, they might have apnea, all that might occur. In liver, there might be presence of acute liver failure. Acute liver failure is commonly seen with defects like galactosemia, tyrosinemia, juvenile or the neonatal hemochromatosis, which is the mutation of hemoglobin. So all this can be present, and in cardiac, usually in diseases like Pompe or FOUD, fatty acid oxygenation defects, all this can have acute presentation, and they might have presence with cardiac failure. So all these abnormalities you have to keep in mind, and these are the organ specific findings. Once you have done all this, the next is the specific things which help you, pinpoint a inborn error of metabolism. So, in glutaric acidemia, in, in glutaric acidemia, in defects like glutaric acidemia, what do we have? Or glutaric aciduria. So in this patient, you have a sweaty feet appearance, sweaty feet odor. It smells like the feet that you get to smell when you have a long day at work, and you have use the shoes without the socks. Then MSUD has a burnt sugar smell, while tyrosinemia and cystinuria have a very sulfuric smell, sulfur type, rotten egg smell. Okay, then hypermethionemia have a boiled cabbage smell, while the patients with multiple carboxylase defect or hollow carboxylase defect, they have cat urine smell or tomcat odor. Okay, phenylketonuria has a mousy smell. Okay, and this is what you need to remember, that these are the common pointers. Now, these patients usually some IEM present with hydrops, very less IEM present with hydrops, and the IEM that actually presents with hydrops are the LSD, lysosomal storage disease, in then Zellweger syndrome is the congenital absence of peroxisomes. Then congenital defects of glycosylation. They usually have the inverted nipple appear. They have usually inverted nipples. And mitochondrial disorders, mitochondrial defects. Okay, so all this might have presence of hydrops or in utero death. Now, whenever a patient comes to you, the initial evaluation for all patients with suspected IM is GALAC, GALAK. E stands for glucose, A stands for ammonia, L stands for lactate, A stands for acidosis, and K for ketone. So these are the mandatory investigations that you have to do, because all the algorithms that we will be henceforth studying have the presence of all these abnormalities. So GALAC is a very important mnemonic that I want you to remember. Okay. Now, whenever you have a patient of hypoglycemia, whenever you have a patient of hypoglycemia and you are suspecting IM, the next step you go for is ketone bodies. So with ketosis and without ketosis. So what happens is, whenever there is hypoglycemia, there should be technically activation of the gluconeogenesis pathway, which would in turn burn fat to create ketone bodies. So with ketosis is the ideal or the real phenomenon. Now in with ketosis, the next investigation you go for is lactate. So increased lactate or decreased lactate, yeah, normal lactate, normal or decreased. So whenever you have patients with increased lactate, usually you have fructose biphosphatase deficiency. or glycogen storage type 1, that is von Gierke disease. So in von Gierke, there is hyperuricemia, hyperlactatemia, hypertriglyceridemia, hypoglycemia, hypoketonemia, hyperketosis. So ketosis is increased, and even mitochondrial disease. While where there is normal or normal lactate, usually it is organic acidemia. Okay, so this is what the ideal findings are. Okay, now without ketosis can also have increased lactate, and without ketosis with increased lactate is seen with fatty acid oxygenation defect and HMG-CoA lyase deficiency. HMG-CoA lyase deficiency and normal lactate is seen with hyperinsulinism. Hyperinsulinemic hypoglycemia that is seen has normal lactate because insulin is there to prevent ketosis. Insulin is there to prevent huge amounts of gluconeogenesis. Okay, or HMG-CoA synthetase deficiency. Synthetase or synthase deficiency is the ideal example for this. Now, the presenting feature you saw is metacidosis. So in case of metacidosis, again the next step you go for is ketosis. If the ketosis is present or if the ketosis is absent. So if the ketosis is present, next investigation you go for is ammonia. In ammonia, if the ammonia is high or if the ammonia is normal. Now again, if the ammonia is high, the next investigation you go for again is the lactate. And if the lactate is increased with high ammonia and ketosis, the deficiency is the specifically proximal urea pathway defects. Okay, while in normal lactate usually you have organic acidemia. Okay, now in normal ammonia with ketosis, again the next investigation you go for is lactate. Again the next investigation you go for is lactate. So if the lactate is high, you have to check for hypoglycemia. If hypoglycemia is present with increased lactate with normal ammonia, it is again fructose biphosphatase deficiency and GSD1. While if the patient has normoglycemia, you can suspect mitochondrial disease. Okay. While in case of normal lactate, again you check for hypoglycemia. If the hypoglycemia is present, it is organic acidemia or adrenal insufficiency. While if hypoglycemia is absent, meaning the patient has normoglycemia, then it is maple syrup urine disease or ketolysis defect. Okay, so this is the approach. Now, without ketosis, in patients without ketosis, the next investigation you directly go for is lactate. Okay, if the lactate is normal, it is renal tubular acidosis. There is the patient is suffering from acidosis and there is no ketosis or no lactate. The reason for the acidosis is renal tubular acidosis. While if the lactate is high plus there is hypoglycemia, you have found fatty acid oxidation defect. While if you have normoglycemia, then it is pyruvate dehydrogenase deficiency, PDH, pyruvate dehydrogenase deficiency. So this is the second approach that I want you to remember. Now the third and the last approach that we will remember for today is hyperammonia. Approach to a patient with hyperammonemia with acidosis. Okay. So next is the patient is having acidosis or patient is not having acidosis. So acidosis is absent, acidosis is present. So next investigation you go for is presence of organic acids in urine. And organic acids in urine is measured by the single investigation by the name of urine GCMS. Now, whenever you have organic acid in urine, you have two differential diagnoses, organic acidemia and foul. And this you can easily differentiate by the presence of acyl carnitine. Okay. Now, next investigation after acidosis, if you go and there is increased lactate, it is pyruvate carboxylase deficiency. Pyruvate carboxylase deficiency. Now, in patients with no acidosis with low to normal glutamine, because the glutamine is the predominant amino acid in the body and the biggest source of ammonia. If it is normal or low, the deficiency is HIHA. What is HIHA? It is hyperinsulinemia with hyperammonemia, or there might be presence of citrine defect. Okay, so all this can be seen in patients of no acidosis with hyperammonemia. Now, whenever you have increased glutamine, okay, increased glutamine, the next investigation you check for is citrulline. Okay, citrulline. Now, if the citrulline is low, if the citrulline is low, or if the citrulline is high. So, if the citrulline is low, you can divide it into two parts depending upon the levels of orotic acid. Increased orotic acid in urine is seen with ornithine transcarbamylase deficiency and triple H syndrome. That is hyperammonemia, hyperornithinemia, and hypercitrullinemia. Okay, even arginase defect is a part of increased orotic acid with low citrulline. In patients with low citrulline and normal orotic acid, it is carbamyl phosphatase synthase deficiency or NAGS and acetyl glutamine synthase deficiency. So either CPS deficiency or NAGS deficiency. CPS is carbamyl phosphatase synthetase deficiency. NAGS is an acetyl glutamate synthetase deficiency. While high citrulline, next investigation you go for is dependent upon the levels of ASA deficiency, which would help you seal the diagnosis. So I guess that's all for today, guys. The treatment and the other investigations will be covered in the second part of the lecture, and I will see you in the next one.